What we're doing is I've been in the world of interventional pain management, and I've taken care of patients for 25 years. And the thing that always bothered me is that I would do procedures and the patients wouldn't have durability in the procedure. The procedure wouldn't last. And I kept wondering, why is it the procedure's not lasting? And I'd look at their imaging studies, and the imaging studies looked better, but the patient had symptom recurrence at 6 months. So I was constantly trying to figure out, why is this not working? Like, what's going on? And so I ended up looking at this very closely and came to some conclusions that it wasn't necessarily the fact that I screwed up my procedure, because the patient had gotten better, but it was because the patient was generally not well. They had a metabolic problem. And as I started doing research in this, I ended up getting boarded in obesity medicine, addiction. I was already boarded in anesthesia and intervention pain. But I ended up doing a pretty deep dive and becoming an expert in this area. And the conclusion was that in the 30s, the vast majority of patients were healthy, and only 20 to 30% were unhealthy. By the late 70s, it was about 35% of the patients were unhealthy, and 70% were healthy. In the 80s, 5 years after 1979, we started to see a massive shift in obesity, and it skyrocketed thereof. And it went to 60% unhealthy, then 70% unhealthy. And then before COVID, it was 83% unhealthy, 17% healthy, 83% unhealthy. Post-COVID, 93% unhealthy, 7% healthy. And of the patients that come to medical care, 1% healthy metabolically, and 99% metabolically sick. This is an issue of prediabetes and hypertension, anxiety, depression. This is the cause of 80% of our cancers. This is the cause of most of our psychiatric disorder. It's $1.3 trillion in the US economy a year. It's metabolic dysfunction. And the problem is that the standard testing that we use doesn't see it. So a hemoglobin A1C is wrong 75% of the time to diagnose diabetes. It underestimates it. A TSH T4 is wrong 40 to 60% of the time to diagnose hypothyroidism. A GGT is wrong 40 to 50% of the time. I'm sorry, an SGOT, SGPT is wrong 40 to 50% of the time to diagnose fatty liver. Fatty liver is the number one cause of liver transplantation in the United States, and it costs us $1 million a patient to do that. And so what's happened is that the tests that we usually look at underestimate the problem, and so we're missing the problem. If you look at people's populations and you look at how the government looks at things, people are born, they consume some healthcare resources, they become neutral to society, then they're productive for a period of time, and they make money for society. Then they have senescence, they start to decline, and then they start consuming more resources than they generate. And the longer that they spend in this area under the curve, where they're not doing very well and they're consuming a ton of resources, and they're sitting in a nursing home with a diaper and they've got cognitive impairment and they don't know their name, the longer that is, the sicker that population is, the more money it costs to take care of them. And if the population in general, more of it becomes here than in the productive area up here, in this area, in this healthy area that they're producing, if more of the population is down here, we got a problem because we can't support them. My job is to increase health span. It's to increase their effective robustness. So I keep them in the work zone longer, and I keep them in the functional and resilient zone longer, in fair and good health, and shorter time period area under the curve in poor health. Ideally, I'd like to increase health span. This number is 9.8 years it's been measured, and we were well defined. The difference is 1,150% for healthcare resource consumption if you have increased health span versus you have regular health span, even though you die at the same age. But my goal is to expand lifespan and health span. I don't want to expand lifespan without expanding health span, because otherwise, if I just expand poor health lifespan, then the area under the curve gets even bigger, and it gets then we could bankrupt our entire healthcare system. So what we're trying to do is to get to this. And what we're doing is we're using tests that are well recognized. We're not making things up. We're using existing technology, but what we've done different is that our technology is integrated one part to the next. And when we integrate it correctly, we're able to get amazing outcomes. And we're able to do it very quick. And so let me kind of walk you through that. There's 4 components to it. There's an intake analysis and biologics. Intake analysis is a review of systems that our technician does. And biologics is some blood testing or saliva testing or whatever testing we need based upon the review of systems and standing orders. So if a patient comes in and they're obese, we can measure LPIR. If they come in and they're at risk for non-alcoholic fatty liver disease, we're going to measure their GGT. If they're at risk for having issues with cognitive impairment, family history, or they're losing memory, we're going to measure ApoE5. So there's particular testing that we do, which is based off of an AI algorithm that we enter in, and I'm going to show you that in a second. And then those biologics.
That's one of the questions. That was one of his first questions. What is it that you do to get to examining that the patient is eligible? I said, well, we use urine, saliva, and the swab. He said, so why do you use those? What do you need the urine for? What do you need the blood for? And what do you need the swab for? And I told him the swab was needed for the genetic.
Well,
I didn't know the urine.
So
okay.
The swab actually has 2 components to it. Do you want to watch people pee in a cup?
No, I don't.
Okay. So the swab is an easy way to get a sample of saliva that tells you what their urine toxicology is going to be. And you can have chain of custody without watching them pee in a cup. So if you have a suspicious patient, especially if you do addiction medicine, I don't want to go in there and watch them pee in a cup. Oral swab in their mouth, and 3 minutes later, I've got a saliva sample from that patient with chain of custody that I've identified, and I can send that off, and I get the same results as I would off of a urine. And it's 100% accurate, and I know it's that patient, rather than addiction patients are crafty. So they'll bring in warm urine from somebody else, but they're not going to put in warm saliva in their mouth from somebody else because you're watching them the whole time. So you're actually going to get real data.